Hey everybody, this week we are in chapters 22 and 23 covering newborn adaptations and newborn care. We are in week 7. It is week 7 and we are starting to learn about newborn care, which is chapters 22 and 23. So we're going to jump into that content this week, in fact right now as you're watching this. Also due this week are your teaching plan. Make sure you follow the rubric. We're talking about this in a little more detail in class, so of course ask me any questions if you're unclear and don't wait till the last minute. Also, your next CJ Sim assignment is due and discussion number 3. So make sure you're managing your time this week and don't wait till the last minute on all of those items. This slide, if you open up your PowerPoint itself, will be a video. In the voiceover, it doesn't show the video, so I won't play it right now, but you can watch it when you view the PowerPoint. And just be looking for some of those initial interventions that we do right after the baby's born. We're putting the baby skin to skin. We are drying and stimulating the baby with the dry towels and making sure that we remove any moisture from the baby. There might be some things that you see in this video that I would do in a little bit different order, but the main things, of course, we want to do are putting the baby skin to skin, drying and stimulating the baby with those dry towels, and then removing those wet, they've become wet from the baby, taking those off so that we don't lose any heat energy through evaporation. And then we want to put a hat on the baby too for some of those same reasons. So just take a look at that video and see what you notice there. Here we're looking at the APGAR scoring. APGAR is one of the hallmarks of how we're assessing immediately the baby's health in transition to extrauterine life. So APGAR scoring, there are 5 categories and each one gets 0, 1, or 2 points. So first we're looking at the baby's appearance. If the baby is blue all over, that's 0. If the baby is blue only at the extremities, that's also called acrocyanosis. And acrocyanosis is normal in the first 24 hours. The baby gets a score of 1. And that is caused because all sorts of different valves are opening and closing and changing during this transition to life outside the womb. So that can be normal still. And then if the baby is pink all over, then the baby gets a score of 2. Pulse, we go less than 100 beats per minute is a score of 1. Greater than 100 is a score of 2. No pulse is 0. And then grimace, so it's the baby's response to stimulation. If the baby has no response, 0 points. A grimace or a feeble cry, just like a soft attempt at a cry would be 1. This baby might be kind of lethargic, or it's kind of like making little noises, but it's not that nice big lusty cry that we like to hear in the newborn. And the score of 2 would be some of the sneezing, coughing, pulling away. If we're kind of tapping on the baby's foot, it's pulling it away. Activity, if the baby has no movement, that's 0. Some movement but sluggish or lethargic, that's a 1. And then active movement, just the kicking and kind of punching the air a little bit would be a 2. And then for respirations, if the baby is not attempting to breathe at all, no breaths, it would be a 0. If it's weak, slow, or irregular breathing, it would be 1. Irregular, not meaning not a regular rate, because we know that it is normal for the baby to have an irregular rate of breathing. babies will sometimes go up to 20 seconds without taking a breath, and that's still normal. So irregular here is referring more to an abnormal type of breathing, like say gasping or retractions perhaps. But a nice strong cry, you know, obviously with breaths in between, would get a score of 2. Okay, so all of these add up. The maximum score is 10. If the baby gets less than a 7, then it's going to need some extended monitoring and APGAR scoring. So the standard, every baby gets a 1-minute and 5-minute APGAR. So that's that 1-minute APGAR, that initial assessment, and then again at 5 minutes. If the baby, is just like your normal standard baby, kind of, happy, kicking, screaming, and no difficulties with delivery or birth causing issues, then a 9 is very common, because very often the babies might still have that bluish hands and feet. So it's, like a 9-9 APGAR is really common. It might be an 8-9 APGAR for one of these other reasons. They lose another point. But if a baby is scoring less than 7, then it is struggling at birth for some reason or another, and the baby needs some continued monitoring. So for these babies, we continue every 5 minutes after that, standard 1 and 5 minute scoring, up to 20 minutes. And by that time, for sure, we've got a neonatologist and another staff there kind of helping to assess and see what we need to do next with that baby. There is another video on this slide that you can view within the PowerPoint itself. I encourage you to do that, get another just kind of perspective and some visual looks at the APGAR scores. But again, it doesn't cross over in this voiceover, so I will skip it here for now, but I encourage you to go look at that. Okay, so in the first 2 hours, we're going to make sure that we are wearing gloves for the birth of this baby. Many newborn nursery nurses will also wear a gown, because we're picking up the doctor is usually handing us the baby against our chest, and then we'll bring it over to put on the mom's chest. We're going to make sure that we, before the delivery, have assessed the risk factors for this delivery. Do we expect it to need some major interventions, because we want to be prepared for that. So we are finding out, what is the gestational age of this baby? Do we already know that it has meconium stained fluid? Does the mom have any pre-existing conditions, or the baby, that they've found on screening or ultrasounds? Also the mom's GBS status, and was she treated with antibiotics? And how did her second stage of labor go? We're also kind of assessing the baby's fetal heart rate during the second stage, and of course right there during delivery. Right after delivery, we're going to be doing that vigorous drying and stimulating that we were talking about, and we're going to suction. We've got the bulb syringe there. We're going to suction the mouth and then the nose. Remember, M before N. And if you think about it, that makes sense. We want to get all of the, thick, goopy mucus out of the airway as best we can, and then suction any out of the nose. So the thing about the bulb syringe is that you want to aim at the sides, not straight down the middle of the baby's throat, causing it to gag. You want to kind of go in from the side on either side. We're going to suction with the bulb syringe, squirt it out, mouth, and then the nose, M before N. Okay. Kind of while all this is happening, we are beginning our APGAR assessment score, where as soon as the baby's born, we start the timer, usually on the warmer. Sometimes you might have a different clock you're looking at, or maybe on the computer you have something, but at the 1 minute mark, just to give the baby a little bit of time to transition and recover, is when we give that score. However, if we see already that a baby is limp and making no effort to breathe, or is just really stunned or struggling at delivery, we're not waiting for that 1 minute and then figuring out the APGAR and then saying, oh, well, then we need to resuscitate this baby, right? That's what this APGAR video is saying as well. You can assess this baby at a glance and you can tell, okay, we need to get this baby some help. So at that point, we would take the baby to the warmer and start maybe positive pressure ventilations, that PPV, and going through our algorithm there to help determine what we need to do. But assuming this baby is nice and healthy and pink and breathing well, we're going to just rub, dry, stimulate the baby and take away the wet towels. We're going to suction the mouth and nose and cover the baby's head with a hat or possibly just, part of the blanket. But that thermostability, the temperature stability, thermodynamics, we want to make sure that we are taking care of this baby's needs. We don't want it to lose its heat by evaporation from the wet fluid on its body and hair. So we want to make sure to dry and then cover. This of course too is because producing heat takes a lot of energy, and any baby is already at risk for hypoglycemia just from the stress of birth and everything. They're all of a sudden cut off from kind of their blood supply. Maybe mom didn't get a lot to eat during labor either, and the baby doesn't have a lot of extra fat stores to either keep it warm or to generate heat with that brown fat. Okay, so temperature is a big thing that we're always looking to be very careful with for these babies. While the baby is skin to skin on the mom's abdomen, we're going ahead and kind of doing that initial physical assessment, just like a once over, right? Make sure we're kind of looking up and down, head to toe for anything abnormal. And we're looking at the cord. We can look at the cord that's still attached to the placenta, or we can look at the cord on the baby's, right on behind the clamp on the baby's side. But we're assessing for 3 vessels. Okay, there should be 2 arteries and 1 vein there. And if the baby is missing a vein, then it's suspicious for different conditions, but especially we'd expect the doctor to look into kidney issues if the baby's missing a vein. You should have a 3-vessel cord. We're also collecting the cord blood. We usually get that from the placenta. The physician or midwife helps drain the cord into a test tube that we'll send to the lab where we test the baby's Rh blood type. And cord gases we can also get too. Some facilities get cord gases on every delivery, and some only deliveries where the baby maybe had a difficult delivery, the baby is not transitioning well, and they are trying to assess whether the baby was acidotic in utero because of decreased fetal heart tones. So cord gases we can get as well. We always get an arterial and a venous, and the veins are always the larger ones. It's easy to find on a cord segment or on the placenta itself. So we collect those so that we can have a comparison, and then we send those off that way as well. This slide is very interesting because it really shows you that kind of transition, that the baby has this period of hypoxia because it's transitioning to using its lungs to provide its oxygen instead of just from the placenta. So these low oxygen saturations are very normal and expected. And if we put an oxygen saturation monitor on the baby, then we would not expect it to be higher than these ranges here. And you wouldn't want to force them to be higher too quickly with oxygen supplementation, because we want to protect the baby's eyes from retinopathy caused by basically toxic levels of oxygen. So we wouldn't expect the baby's oxygen saturation to be within the 85 to 90% range until after 10 minutes of life. And of course, if this were an adult, that would be concerning to us, but for a transitioning baby, that's very normal. This graphic is the neonatal resuscitation algorithm. It is in your book, the first page of chapter 23. And this is what we're going to use, if you've heard of NRP or the Neonatal Resuscitation Program. This is kind of the thought process that we want to use to quickly assess whether a baby needs an intervention to help it with breathing, and where to go from there. So if you start at the top here, these are the questions that we're asking before delivery, the baby's term, and some of those other like pre-existing conditions, right? At delivery, is the baby breathing or crying, and does it have good tone? If yes, we keep it on the mother's chest and provide routine care. And then if no, we are continuing to warm the baby, clear the airway, dry, and stimulate, okay? If then at that moment, so we've assessed the breathing, it's not really working, we're kind of stimulating the baby, drying it, clearing the airway, and then at the same time, by the time we're at 30 seconds, we're listening to the heart rate and seeing if it's below 100, is there gasping or apnea along with it. And then if it's below 100, then we're going to immediately start PPV. That's the positive pressure ventilations. That's with the bag and mask. And we're adding some of the monitors and everything. We're adding the oxygen saturation monitor at the same time. So if the heart rate is above 100, then we are going to continue to clear the airway. If the baby's breathing is labored, we are considering CPAP, so the baby may just need a little bit of help to keep its lungs open during that transition period. At this point, once the baby's stabilized, then the baby may be going to NICU to help it, monitor the baby closely and just make sure that it doesn't crash again. But going down the other left side kind of path there again, with PPV, we are periodically assessing again, okay, is this bringing the heart rate above 100? If yes, then what's the next step that we need to do? If it's below 100, then we're probably not ventilating the baby efficiently. There may be a blocked airway still. There may be something else going on that is not working, because if we're providing the baby oxygen, then the heart rate should be coming up to above 100. If the heart rate is below 60, by this point we hope we have the neonatologist in nearby, or anesthesia can intubate the baby. If it drops below 60, we're starting chest compressions, and we coordinate that with the PPV, and just continue with that. It's running a code on the baby basically, so we're doing chest compressions, PPV, and epinephrine as needed. Depending on, the gestational age of the baby and the different conditions and things going on, then once we intubate, we could consider giving surfactant to this baby if we think that low level of surfactant could be the problem. Based on just other factors and things going on, there could be defects with the baby's airway and different things that are causing problems. But we could also consider hypovolemia if there was maybe an abruption or some other cause of fetal bleeding prior to delivery. And then also a pneumothorax. If we are too aggressive with the PPV, then we could basically blow a pneumothorax, and then the ventilations are not helpful to the baby any longer. So in the first 2 hours, first immediately we, as I said before, we're assessing the baby's airway, making sure that perfusion is going well. We can put the baby skin to skin on mom, and this is really great for a lot of reasons. It helps promote cardiopulmonary stability. So this means that the baby's circulation and perfusion is better when baby is skin to skin on mom instead of over at the warmer. It's really good for temperature stability as well. The mom's temperature can really help stabilize the baby's temperature. And the baby can, and parents can experience this golden hour that the baby is usually nice and alert and ready for bonding there in that first hour, sometimes 2 hours after birth. And it's a really great time to initiate breastfeeding and just allow for that bonding time while the baby is alert and happy right after delivery there, before they go into that deep sleep cycle that usually happens. They're very sleepy the rest of that first 24 hours, and breastfeeding can be frustrating and discouraging. So having that initial breastfeeding go well is really helpful and important. The initial assessment of the baby can be done on the mother's chest, and as long as the baby is, pink and crying and looking like it's transitioning well, then we can keep the baby on the mother's chest for the initial assessments. And even the newborn medication sometimes we give on the mom's chest, just because it's comforting for the baby, and as long as the nurse is able to do it safely without accidentally like sticking herself or the parents or whatever, then it's a good option to be able to do that. So newborn medications, we call it eyes and thighs. The eye prophylaxis in America is the erythromycin eye ointment. This prevents against neonatal conjunctivitis. It's can be caused by gonorrhea and chlamydia. If you look at in your book, it actually says that erythromycin treats gonorrhea. It doesn't treat the chlamydia strain that would cause the Ophthalmia neonatorum. There are other medications that would be needed if we suspect chlamydia, but it's still it's something that we give prophylactically to all babies just in case, because it's easy and extremely low risk. Really no side effects other than possibly some irritation and blurry vision for a few hours. But as long as it's given within the first 2 hours after delivery, then it's still effective to treat the possible blindness caused by gonorrhea if left untreated. The other 2 medications are injections. One is vitamin K. The generic word for that is phytonadione. Both of these injections are given intramuscularly. So vitamin K promotes hemostasis and blood clotting. It increases the synthesis of prothrombin by the liver and stimulates the production of red blood cells. Prevents complications of bleeding for the baby. Vitamin K is normally produced kind of in the intestinal bacteria of the gut, but the gut is sterile at birth, and it takes a little while for the intestines to kind of grow that normal flora and fauna to produce the vitamin K. So we give it routinely unless the parents refuse it to all newborns, whether they're breastfeeding, whether they're formula feeding, whatever. It can just help promote the synthesis of prothrombin in the liver to help prevent the clotting and to stimulate production of red blood cells. Okay. The other injection we give is hepatitis B vaccine, and again, this is routine. We give it even though hepatitis B is sexually transmitted. That is one of the reasons that it's given at birth, because the baby could be exposed to an infected mother in the birth canal, and it's easy, safe vaccine to give. But this is another thing that many parents refuse, especially if the mother knows that she has not been exposed to hepatitis B, she's been tested for hepatitis B in pregnancy, And then again, usually they test again at the hospital. So it's not uncommon for moms to refuse this vaccine for their babies. So the neonatal period we consider to be the first 28 days of life, so the first 4 weeks of life. The major changes we're looking for in infants is to establish and maintain adequate respirations, make sure they're adjusting well to the circulatory changes going on, and maintaining their temperatures. We want to make sure they're ingesting, retaining, and digesting the nutrients given them and eliminating the waste from it, and regulating their weight as all a part of that. As far as behavioral adaptations, we want to make sure that they are kind of getting into a routine of a sleep-wake cycle, and they are kind of making sense of some stimuli and bonding and forming early relationships with caregivers and their environment. That initial transition to extrauterine life, which is occurring in the first 6 to 8 hours of life, kind of has 3 stages. The first stage is that period of reactivity I was telling you about. It's that golden hour. It has the first 30 minutes of that. We expect the heart rate to increase and then decrease to average about 120 beats per minute. This kind of makes sense, right? If you just were born, you have all sorts of different things going on that you've never experienced before. You were just squeezed and pushed and pulled, and then kind of like tossed up on your mom's chest, and it's cold out there and you're not in water anymore. You're all of a sudden feeling gravity and everything. Your heart rate would be increased for a while, I think, just for having that experience. And then it kind of settles down into its 120 average. Again, for newborns, that range of 110 to 160 is normal still. The respiratory rate is going to be irregular, like we talked about. You can have up to 20 seconds that a baby stops breathing shortly, and that still be normal. So we're going to count respirations for an entire minute, and as long as the rate is between 30 and 60, then that is still considered to be normal. As you might expect, the lungs used to be completely full of fluid, and we've had to kind of expel that. So it's not completely dry yet. You might have some fine crackles in there, but these crackles, any grunting, nasal flaring, which we'll talk about in a little bit, or retractions, should improve after the first hour. During this time, of course, like we talked about, the baby is usually alert. We can hear bowel sounds already, and the baby may go ahead and pass that first meconium, and we would establish breastfeeding. The next period is decreased responsiveness. So it's after that first golden hour, and the infant is still pink, but the baby may have kind of more rapid breathing, maybe a little more shallow, but it should not be labored, meaning no retractions, grunting, or flaring. Again, the bowel sounds can be audible, but maybe the baby's getting a little more sleepy here. And then the second period of reactivity can happen. The baby may have periods where its heart rate and respiratory rate are increased, and then it's getting more active, increased muscle tone, changes in its skin color, mucus production. It can be common, especially for C-section babies, but even vaginal deliveries, to kind of gag on some of the mucus, maybe sneezing up a little bit of the fluids. Things like that are still within normal there. Preterm infants, their physiologic immaturity can certainly affect the timeline that this arc and the behavior takes, as you would expect. They may just not be completely developed yet in that area. So if you want to look in your books, you can find box 22.2, which I actually have on the next page, showing some of the sleep-wake cycle, like classic looks of it. But many things can affect, what's considered normal behavior for the baby. I already mentioned the gestational age, but different other environmental factors and especially medications that may have given the mother can affect if the baby's still kind of feeling sleepy or lethargic. As far as social interaction, the 8 to 12 inches from the face is kind of like the perfect range for the baby to see as best it can right now, which by no coincidence, I think, as many things are so amazing in childbirth and labor and delivery, that is the exact distance from the mother's eyes to her arm where she's cradling the baby. So it's kind of the perfect distance for the baby to be able to see and interpret eye contact. And it, of course, can hear as well. It would be listening for mom's voice, rhythmic sounds, especially her heartbeat if the baby's put on her chest. It can also smell. There's a unique sense of smell for the baby. There's studies that show that a baby will turn to its own mother's breast milk if, say, like what are they called? The breast pads that absorb breast milk are put one on either side of the baby's head, near its head while it's laying down. It'll turn to its mother's breast milk because it can sense this unique smell that is unique to that baby and mom. Babies prefer sweet tastes. We give Sweet-Eeze if we anticipate a painful procedure, and it can be comforting and a form of pain control as well. And then, of course, it can interpret touch. The feet are most sensitive. You have seen all sorts of different types of babies. They already have different temperaments at that age. They might be reacting really strongly to different things in the environment, like loud noises or touch or bright lights or whatever. And some babies just don't even care. They're just going to lay there. So their temperaments are already kind of coming out. But they can become accustomed to certain stimuli over time. So all that's normal as well. They have learned behaviors like consolability if they are left to self-soothe, maybe use their hands to soothe themselves, versus if the parent holds and rocks them all the time or even nurses the baby to sleep. And then, of course, at the bottom there, crying is how a baby communicates, right? If the baby needs something, it can't communicate, so it's going to cry and fuss and let us know that it's uncomfortable or unhappy for whatever reason. So we just kind of go through the list of possibilities until we find the thing that is bothering them. So here is the sleep-wake cycle there. You can see in box A, the baby's in deep sleep. And then B would be more of a light sleep. C, the baby's drowsy but not asleep yet. And D, the baby's quiet and alert. And E, the baby's more active and kind of following you with his eyes, maybe moving a little bit. And then obviously the baby's crying in picture 7. So as far as the respiratory changes, and the initiation of breathing that happens in the transition during and after birth. During labor and birth, you have decreased oxygen levels. Every time there's a contraction, right? It's constricting blood flow through the placenta to the baby. And the baby recovers as long as the heart rate is doing well and is a reassuring heart rate pattern. But this kind of pattern of decreased oxygen and increased CO2 in the baby's bloodstream while in labor it kind of helps stimulate the signals to the brain, like I need to breathe, right? So immediately after birth, the baby's already kind of primed for that initial reflex to begin breathing. The change in intrathoracic pressure, this is like when the baby's getting a squeeze, especially in vaginal deliveries. They do try to simulate it some when they can with a C-section. They kind of keep the opening small and let the baby get a good squeeze on its way out to help not only squeeze out whatever fluid and things out of the lungs during that initial birthing process, but also the it's almost like the rebound pressure creating a vacuum that helps fill the lungs, kind of helps initiate that breathing, because of course right before delivery the lungs are full of fluid. Very dependent on surfactant. As you remember, surfactant decreases the surface tension and allows the alveoli to open up and have a good surface area for gas exchange in the lungs. And as I mentioned there's with C-sections, it can take longer to clear the mucus and secretions. You would expect the baby to have more, be more gaggy and spitty after a C-section, because they didn't get as great of a squeeze there during birth. As far as thermal factors, that drop in temperature, right? The baby's born and all of a sudden it's not in this warm, cozy, wet space anymore. Now it is wet, but it's in the air and it's cold, and also the room is cold, and it's just kind of a shock, so they just take that initial breath out of shock as well. The stimulation to the respiratory center, we already mentioned. The brain is kind of primed for that. There's signals already being sent to the medulla to say, hey, we need to take a breath here. The lungs, of course, are now the site of gas exchange for the baby. It's this immediate transition from placental gas exchange to lung gas exchange. Clamping the cord can cause a rise in this blood pressure, and the breathing is initiated then. Babies are, the term used now is preferential nose breathers, meaning they want to breathe through their noses, and they have a hard time if their noses are occluded for any reason. And it's in the first 3 weeks they actually don't have the reflex like we have or older babies have to open their mouths and breathe through their mouths if their nasal passages are blocked. So they are truly obligatory nose breathers in the first 3 weeks of life, and that is of course very dangerous because if, say, even during breastfeeding the baby's nose is occluded, or during skin to skin, the baby's put face down on the mom's chest, if the parents aren't careful to look and make sure that the baby is able to breathe through its nose, then the baby could have sudden apnea, and then we're in an emergency, right? I mentioned before, but here it is again, the baby can go up to 20 seconds without a breath, and still that's normal, okay? It's very irregular. It can kind of breathe quickly, 10 breaths very quickly in a row, and then a 20-second gap, and then 20 more breaths before that minute is up, and then you're still within that 30 to 60 respiration rate, and that's still normal. Okay, you will notice abdominal breathing as well, so they're really taking those nice deep belly breaths like they say to do if you ever took a choir class or anything. They're breathing with their diaphragm, and so you can see kind of their bellies rise when they take a breath. So we're going to talk about the signs of respiratory distress now. So these are some of the initial things that we would look at as soon as the baby's born. We look and see, are we concerned or are things okay? So respiratory distress, of course, it affects the color of the baby, and that'll be one of the big initial things that we are looking at. just as the APGAR scoring suggests, we're looking for if the baby's pink all over, just the extremities blue, or if the whole baby is blue. We're also looking for circumoral, if it's blue around the baby's mouth, then that's obviously a concerning sign, more than the extremities, right? So this term acrocyanosis is the bluish hands and bluish feet, and that is normal in the first 24 hours. So if we're seeing acrocyanosis, bluish hands and feet, that is not necessarily a concerning sign or a sign of respiratory distress. What we are looking for is respirations outside of the 30 to 60 respirations per minute range. So tachypnea is a big one. Tachypnea, the baby's breathing too fast. It might be that there's still a lot of fluid on the lungs. Other reasons of respiratory distress could be because of cardiac reasons, that the respiratory rate, the baby's compensating. It could be caused by infection as the root cause of that. For whatever reason, the baby's not perfusing very well, and it's compensating by taking more breaths, a faster rate, right? Meconium aspiration is one possible reason for this. If you suspect or if there's confirmed meconium fluid passage in utero, and the baby might have had some of that fluid with meconium in its mouth that it inhaled into its lungs, then the meconium can basically inhibit the gas exchange in the lungs and cause meconium aspiration syndrome, respiratory distress. So another fairly common, or something that we're really looking for, is transient tachypnea of the newborn. So this is for no real obvious or apparent reason. When the baby starts breathing too quickly and starts having some of these other signs of respiratory distress we're going to talk about, it can kind of happen suddenly. Maybe the baby transitioned fine, but then, 6, 8, 12 hours later starts breathing really quickly. Sometimes it's just this transient tachypnea of the newborn where the baby is struggling and needs a little bit of help. So we're going to get somebody in there to help further assess this baby, possibly NICU nurses, possibly the neonatologist, and give some recommendations for how to assist this baby. Sometimes they might need oxygen, sometimes they might need a little bit of CPAP for the first day or two, and then usually they transition just fine back to the mother. But some of the signs that we're looking for, you can use this acronym WET FROG. The 3 classic ones, though, are listed in that transient tachypnea bullet point there. It's the grunting, flaring, and retractions. We're going to see an example of this in the video on the next slide. But if you go with this acronym, you're listening for wheezing. You are looking for increased effort, right? So it's this work of breathing. If this baby is having to work this hard to take breaths, then it could not be far from just crashing. Its blood sugar might crash, it might get lethargic, it's crashing too much to then sustain these increased rate of respirations, and then, just everything goes downhill from there. So if the baby is working really hard to have to breathe, so we're looking for other types of retractions there. Here it lists the supraclavicular fossa. So these inhalations are sucking in up here by the clavicles. If the baby's working really hard, then that's not a good sign. Tachypnea we already talked about. Nasal flaring we'll see in the next slide, but basically with every breath the nares flare, and that's an increased work of breathing as well. Retractions could be intercostal or substernal. And then, of course, oxygenation, we're looking at color, especially the mucous membranes like the circumoral area like I was telling you about, and then grunting on expiration. Grunting, we'll see an example of as well. Just know that it can sound like a cry, especially to parents. It almost seems like the baby is softly crying and you're kind of like, "Aw, listen to the baby, how cute, how sweet," and they don't realize it's a sign of respiratory distress. So a cry is a little bit different, and a grunt will be on every exhale. It's almost more like this, it almost sounds like the baby's kind of giving up with each breath. So it's kind of like a breath in and then okay, so it's more like just a grunt with each exhale. Let's look at the next slide. And this video is available in your course resources as well for this week, so you can link directly to it if for some reason it's not showing up on the recording. This is an excellent video that shows retractions on a baby. This baby is not a brand newborn, but it's obviously having some respiratory distress. So this is another video for you to view within the PowerPoint itself, and I encourage you to open that document and click on the video and watch it from there. You could see in that video the little baby with the severe respiratory distress going on. We're looking in several of these cases at chest movement. So there are different types here. We're not going to be really scoring these as this chart shows as nurses, but there's still things that we need to be aware of because we can notice these things on every assessment. So we're looking for whether the respirations are synchronized, that the chest movement has this normal rise and fall, or is there a little bit of a lag or even a seesaw kind of motion going on here. We're looking for retractions, whether they are, hopefully there are no retractions, but if they are just barely visible or marked. And then you might see a retraction on the xiphoid area. We saw a couple of those in those babies in the video as well. And then we're looking for flaring of the nares, so nasal flaring, and then grunting. Some grunting you can hear only by stethoscope, and other grunting you can hear audibly just by listening to the baby. Take a look at this video in your PowerPoint as well. It's another good video showing retractions. The first few seconds aren't as clear, but especially toward the end of the video, you're going to see some clear retractions and grunting as well that you hear on exhalation. Okay, on to cardiovascular system. So in utero, the fetus has a circulation pattern that is different from a child or adult outside of the womb because of several shunts that are open, and then what happens through a series of events at birth, those shunts close ideally, and then they change the circulatory system to allow the blood to pass through the lungs and retrieve oxygen there. So one of these shunts is the foramen ovale, or oval, depending on who you talk to. This is the opening between the atria. So this is open in utero, and then it shuts when the cord is clamped, and the systemic vascular resistance increases. All of a sudden, there's a shorter distance for all the fetal blood to travel because it's not traveling up the umbilical cord, which closes the foramen ovale. There's also the ductus venosus, which bypasses the liver. It carries oxygenated blood from the umbilical vein to the inferior vena cava, and after birth it's not needed anymore, and it converts to a ligament in the process over time, over about 2 to 3 months. And then the ductus arteriosus, it means that in utero, the blood is bypassing the lungs because the lungs are not needed in utero to provide gas exchange. It starts to close in the first 24 hours, and it's one of the murmurs that may be heard in infants normally in the first 24 hours. And it also becomes a ligament once it is closed and stays closed. If it does not close, it is a problem because what happens is the oxygenated and unoxygenated blood is mixing, and the baby is not getting high oxygen concentration in all of its extremities and organs in that case because it's mixed. So this condition is called patent ductus arteriosus, or PDA, meaning that it's patent, it never closed, and that is a problem. It's a disorder if that occurs. So as I mentioned, the the process of clamping the cord, or if the cord is left unclamped, you know, just the as the placenta, you know, the body detects that birth has happened, the placenta detaches, there's not the circulation there anymore, and it starts to sort of dry up, and these changes happen either way. So once the baby takes its first breath and the lungs are inflated, then there's a decrease in pulmonary vascular resistance. And all these changes put together cause the various ducts to close, or the shunts to close, and the circulation is working as it should be. As far as cardiovascular assessment, normal heart rate is 110 to 160, just like in utero. We are going to assess the apical pulse for a full 1 minute, and we're going to be listening for possible murmurs. As I said, the ductus arteriosus could cause a murmur in the first 24 hours, but sometimes other murmurs are present as well, and if they are not going to be permanent and pathological, then as long as they disappear within 6 months, you know, obviously this would be up to the pediatrician or the specialist to evaluate and confirm, but these are often, you know, not unusual findings. So we're assessing for murmurs and we're reporting the murmurs, but we're not necessarily panicking about it. We're just going to report it and let the neonatologist follow up on that. The point of maximal impact is the fourth intercostal space at the midclavicular line, which is where we're going to place our stethoscope. And of course the heart rate is going to vary depending on if the baby is active or sleeping. You might have persistent tachycardia if the baby is hypovolemic, right, because it's compensating for the lower blood volume. So the heart would need to pump faster. Or sepsis can cause tachycardia as well. You might have persistent bradycardia if there's a congenital heart block, hypoxemia as well. The blood volume is slightly increased if the provider does delayed cord clamping. This is recommended really for all infants whenever possible if the baby isn't already in distress and needing to just immediately clamp the cord and go over to receive resuscitation. But it's especially important for preterm infants. It can also decrease necrotizing enterocolitis, which is obviously important and helpful for those preterm babies. There is transient polycythemia though, so the red blood cells are increased because of the extra blood volume, and that can increase the risk of hyperbilirubinemia and jaundice. So that's kind of a trade-off with the delayed cord clamping, still an overall recommendation. Signs of cardiac defects might be that difficulty breathing, okay? Blue, you know, cyanosis or pallor. Pallor would especially be hypovolemia if the baby is suspected to have lost any blood and you're noticing pallor, then that would not be reassuring. and you would want to look more into that. Poor feeding as well. Poor feeding could be a sign of cardiac defect and or respiratory distress or defect. And then unusual or absent pulses. Okay, we're talking about thermoregulation next. So the baby's temperature control. As I mentioned earlier, this is very important, and it's one of the things that can really affect the baby's well-being because it requires so much energy for the baby's body to be regulating its temperatures. Notice here too in this photo, this baby has some acrocyanosis. Its hands are kind of blue and its feet are kind of blue, and again, that's normal. This baby has obviously just been born. Its hair is still kind of like icky looking, right? And it's like puffy and you know, just it's kind of stunned there. However, you should not, like, for any normal reason, this baby's head should not be uncovered. It should not be sitting there naked in the middle of an open room with drafts all around. There are several things going on in this picture that are concerning to me. So again, maintaining your temperature as a newborn takes a lot of energy. It takes a lot of oxygen and a lot of glucose, and glucose is something that's going to be really important in the first few days, especially as we're stabilizing, because it may be already unstable anyway, depending on the issues with the mother, right? If the mom had issues controlling her blood sugar or anything. But also the baby doesn't have a lot of brown fat stores, especially if the baby is not term. That brown fat is deposited later in the gestation. So if the baby's born early, it doesn't have many reserves there. And that brown fat is what can help produce heat. Babies cannot shiver early on, so they can't, you know, shiver involuntarily to produce heat as well. So apart from respiration and circulation, which we just talked about, temperature regulation is the most critical to the baby's survival. Putting the baby skin to skin on the mother is going to help promote that stability like we talked about. So that's going to be helpful and important. And then there's 4 types of heat loss or gain when we're talking about temperatures. So convection is one of them. This is the flow of heat from the body surface to the air. So convection would be the baby is losing heat straight from its skin into the air. To prevent this, we want to wrap the baby and put on a hat and decrease the amount of exposed skin. So the baby in this photo is extremely exposed and there's no hat on, like I said. Could happen by evaporation. So this is when the heat is lost because of the conversion of liquid into vapor. Anybody that has been at, you know, a theme park and it's so hot outside, and we're walking around and we dump water on our heads or just get our shirt wet or something, we all kind of know this concept. We do not want to have the baby skin wet or to have wet blankets on the baby. This is going to make the baby cold. Okay, so we're going to dry the baby with our towels or blankets, and then we're going to remove those things that we used to dry the baby off with and put dry, warm blankets on the baby. And then conduction would be the loss of heat by direct contact. So this is when we put the baby on cold scales, or we have a cold stethoscope and put it on its chest. But we can provide warmth by conduction if we have a pre-warmed bed, so the warmers, or we put the baby skin to skin with mom. And then there's radiation. So radiation is a little more distant, right? It's radiating off of a surface that is not quite, you know, on you or touching you, but it's close by, and it's just kind of radiating that heat. So windows are one of these, drafts could be one of these. Skin to skin can help minimize this as well. Okay. Drafts are kind of a gray area though. Convection could definitely be considered from drafts as well. So just know that a radiation, a warm object might be radiating heat off of something, and a cold object nearby, think, you know, cold metal or block of ice or something, might be cool. So here's another illustration here of a baby and cold stress thermogenesis. A baby cannot shiver with that involuntary movement, but they might increase their muscle activity to attempt to generate heat, so they might start that kicking and flailing a little bit more. They're also going to default to a position of flexion, so they're kind of curled up to help preserve heat. I mentioned brown fat. That is called non-shivering thermogenesis, and if the body has enough brown fat kind of stored up, it can recognize that it's getting too cool, and it can start metabolizing and breaking down that brown fat and producing heat. Okay, but what happens in cold stress that you can see in this diagram over here, the cold causes an increased oxygen consumption and an increased respiratory rate because of that. You're going to have peripheral vasoconstriction, so you might, if you have a chilled baby, they might be more likely to show acrocyanosis. So it's still something we want to look for, even though it's not necessarily a concerning sign at the moment. It's going to cause pulmonary vasoconstriction, which then unfortunately decreases the oxygen uptake by the lungs. And then there's decreased oxygen to the tissues, which again we might see acrocyanosis. Decreased oxygen to the tissues is then going to cause anaerobic glycolysis or glycolysis. So it's breaking down the sugars. It's using sugar to help compensate for this. And it's anaerobic, which means that it is putting off acids into the bloodstream. It's causing metabolic acidosis and hypoglycemia. Okay, so all of these are problems, as you might expect, but you can see how a temperature that's too low, it's causing cold stress in the baby, can end up crashing the baby. So it's very important to keep the baby warm. Under the warmer, skin to skin is the best choice, but under the warmer or with the warm blanket and hat as well. However, we want to be careful to prevent hyperthermia as well, because the baby also cannot compensate very well for high temperatures. If the baby's temperature is greater than 99.5, it's considered hyperthermia. This can be caused from inappropriate use of heat sources. So the radiant warmer, it might be turned up too high. We might have the baby wrapped in too many warm blankets, not allowing enough, air flow and exchange. You might have the room too warm, plus the baby is, too wrapped and covered and under the warmer. So there are all these different factors, and it's another reason that skin to skin is really the best, because if the mother is, the baby will regulate its temperature to the mother's. So the mother's kind of still doing the hard work in her body of regulating her temperature, and it helps regulate the baby's as well, and really decreases the stress to the baby. Sepsis, though, of course, is another reason that the baby might have high temperatures that we would be watching for. Moving on to the baby's kidneys, we're looking at the renal system, fluid, and electrolytes. We are looking for the baby to have its first void in the first 24 hours. It is not uncommon for it to be a while, and the parents are wondering, why isn't the baby peed yet? But it's normal and okay as long as the first void happens in the first 24 hours. That's all within normal. And it's, you know, a relief when we see that first void, because if we don't, then we're concerned why. And we might be concerned anatomically. Is everything patent and open? All of the plumbing is there, as we might say, and everything's working correctly. Once milk has come in, sometimes that's not until day 4, but we want to see 6 to 8 wet diapers a day. That is the best way to assess the baby's fluid, electrolyte status, to assess the baby, whether the baby's getting enough to eat, because it's got this perfect ratio, right, of solids to fluids in breast milk, and we want to see 6 to 8 wet diapers a day minimum. Between day 1 and day 4, you know, there might be a little bit of a variation with that, but 6 to 8 wet diapers a day is kind of our golden target there. The baby's body is 75% water. And a lot of the weight loss that we see in the first few days is just extracellular water loss. And it's, again, just some of those, just like the mother, there's lots of fluid shifts going on, lots of changes going on intracellularly and extracellularly for baby and mom. So that weight lost in the first few days is not all necessarily weight as in fat or tissue lost because the baby's consuming so much energy or anything. However, excessive weight loss can be from feeding issues, okay? So we are hoping that the birth weight doesn't decrease by more than 10%. So we are weighing the baby. The baby will follow up at the pediatrician's office as well and make sure that the baby doesn't lose more than 10%. And if so, then we're probably going to recommend supplementation with either donor breast milk or formula. Okay, so we want to make sure that the baby's eating 8 to 12 times in 24 hours. It's not necessarily having to be every 2 to 3 hours. They can have a little bit of fluctuation in that. Like, it's okay if they go a little bit longer than 3 hours, but then their next feeding might be in 2 hours, and there might be sort of an ebb and flow depending on the patterns with the baby. But 6 to wet diapers a day, again, is kind of the golden target there. And you can see the way we calculate birth weight down there. You basically just have your birth weight and you subtract the current weight, and then you divide it by the birth weight. And when you multiply it by 100, you have the percentage there. Gastrointestinal. We are looking for things like the baby responding to feeding cues. Those are some of the reflexes, right, that we're looking at as well, which we'll talk about. We're looking for the baby to be able to coordinate sucking, breathing, and swallowing. The fact that they prefer to breathe out of their noses can help with that coordination some. The capacity of the baby's stomach varies with the infant's size. Rule of thumb is about the size of the baby's fist by the time they're, 10 days old. But day 1, it's just the size of a marble usually. But again, it depends on the baby's size. If you have a very preterm baby, then it would be even smaller than that. But the point is, they really don't need much fluid, especially at the beginning. And it would increase every day, which again, by no coincidence, kind of corresponds with the amount of milk the mom has to offer, because there's just a small amount of colostrum available, usually on day 1. So the intestinal microbiome, again, the flora and fauna, but the flora is established in the first week of the baby's gut, which helps synthesize vitamin K. But that usually doesn't happen until about the first week, so that's why we give that vitamin K shot. The mucosal barrier in the intestines is not mature until 4 to 6 months, which is why we don't recommend, and actually recommend that parents do not supplement with solid foods until 6 months. And then the microbiome, or lack thereof, can increase the risk of allergies and infection. breastfeeding decreases that risk. It helps kind of, if you think about like an inoculation, like exposure to a small amount of an irritant can help the body develop, with inoculations, it's developing a resistance to it. With breastfeeding, it's more like developing an accustom to it. So by the baby being exposed to some of the things that the mom is exposed to, the baby could be less prone to allergic reactions from certain foods and things when solid foods are started. The baby might have reflux. So this spitting up, it can be normal in the first 3 months. So their valves are just relaxed, and so some of that is very normal, but projectile vomiting, or especially if it's painful for the baby, so it's accompanied with these high-pitched cries, that might be GERD or gastroesophageal reflux disease. That can cause, just painful. It's painful for the baby, and it can cause aspiration as well because there's constant regurgitation, and the baby might aspirate that at some point. Meconium. So the baby's first stool is that big, thick, tarry poop you might have seen before, and this is normal for the first stool for sure, maybe even the second or third shortly thereafter if they didn't get it all out there first. And then the baby's going to start to transition. This is more like a green. It's kind of like a black and green kind of mixed together. This would be by the second day you're seeing those transitional stools. And then by the 4th day, if the mom is breastfeeding, you're going to expect to see a yellow, seedy, sometimes it's bright yellow, and it literally looks like it has like sesame seeds in it. It's normal to be very, very soft, and that's what we expect with breastfed babies. Formula-fed babies, the poop stinks a little more, and it's more mustard-like yellow instead of this bright yellow. Sometimes even like a brownish yellow. But the meconium, again, it's formed in utero. We want to see meconium passed by 48 hours, and if not, then we're looking for a reason why. If there's a bowel obstruction, we always test when we're doing baby assessments, we're testing and making sure that there's an anus present, because maybe that's the reason why the baby's not passing stool. Other congenital disorders would also be considered if the baby's not passing stools yet. Again, signs of problems might be if the baby's not pooping, if the baby's projectile vomiting, or if the baby's squirting water, basically this high water content of stools. Okay, so moving on to the liver. The liver is where we store some things in addition to filter things. So we're going to be storing our iron there, but we're also storing glycogen there. So the liver has a big role in glucose homeostasis. So we think of, the pancreas as kind of stabilizing the blood sugars, and it does, but the pancreas produces insulin, which lowers our blood glucose if our blood glucose is too high. But the liver has glycogen stores, which if our blood sugar is dropping too low, it can help release glucose into the bloodstream. So we have this initial drop in glucose at delivery because all of a sudden we're cut off from the mom's blood sugar supply. So this first feeding as soon as possible is really important to help kind of stabilize that. We mentioned a lot of these before, but some of the signs and symptoms of hypoglycemia would be if the baby's jittery, lethargic, apnea, slowing, like everything kind of slowing down, right? Feeding problems, and and ultimately seizures. The baby may also be asymptomatic, and we're not routinely checking blood sugars on the baby unless we see a reason to. But again, if the baby is having trouble controlling its temperatures, then we're going to be checking blood sugars. Of course, if the mom is diabetic, we're going to be doing that too. Fatty acid metabolism. So the liver also can break down fatty acids to provide a source of energy for the baby. And the most likely problems, liver-related problems, would be hypoglycemia because of either inadequate stores or inadequate usage of the stores in the liver, and hyperbilirubinemia, which we'll talk about, which leads to jaundice. Other things, coagulation factors. So vitamin K helps the blood clotting factors form in the liver. And then transient blood coagulation deficiency is due to a lack of vitamin K, and you could have vitamin K deficiency bleeding. So again, that's why we give vitamin K supplementation. Okay, now we're talking about bilirubin. If you look at the pictures to the right there, that's the baby on the top has increased bilirubin. It's jaundiced, right? It has unconjugated bilirubin circulating, and it's causing jaundice in the baby. The picture down below is showing facial bruising. So if a baby has any issue with bruising or things like a cephalohematoma, it is at an increased risk for jaundice, because anytime you have blood, extra blood that needs to be broken down, one of the basic byproducts is bilirubin. Well, if it's unconjugated bilirubin, the body needs to conjugate it, but the liver is immature, and it is unable to do that very well. So there might be some times that we need to help the baby out. But starting back at the top of this slide, the bilirubin, once we have any bilirubin, our body's trying to process it, and it excretes it in the feces. So we're looking for and trying to help the baby pass stools. Kind of the more the better. But so we want to increase feedings. It increases the volume for the baby and increases peristalsis for the baby, so that the baby can pass its stools. First it's meconium, and then it's transition, like we said. Colostrum is a really great natural laxative as well, so that helps stimulate that process. Make sure to look in your book for references for kind of how this happens. But again, one of the physiologic things that could cause high bilirubin levels are any extravasated blood, and then of course the immature liver. You also could have a hemolytic disease that's causing the bilirubin levels to be high. You might have a positive Coombs, where you have that ABO-RH incompatibility as well. But there is a type called related to breastfeeding. It means when a baby is breastfeeding, it's not caused by the breastfeeding itself, but just by the fact that there's not as much fluid volume as when you are formula feeding. So the remedy there is to attempt to increase feedings, maybe increase pumping and giving to the baby, maybe donor milk if needed, or supplementation as kind of the last choice, but still a valid choice if needed. If the bilirubin levels get too high, you could have acute bilirubin encephalopathy. The baby is basically getting toxic, and the baby can get hypertonic, can cause seizures and coma and death. So we definitely want to avoid this. Kernicterus is also a sequelae of high bilirubin. It is irreversible, causes hypotonia, cerebral palsy, and delayed motor skills. One of the ways that we might treat high bilirubin levels would be with phototherapy, which is ultraviolet light, and we can use a bili blanket, or we can use what's called a bank light, which is basically just you know, a light that sits above the baby's bed and shines down on it. And we would need to provide eye covers for the baby the entire time it's under the lights. We try to keep the baby under the lights as much as possible, asking the parents to only remove the lights for feedings. The bili blanket really can help with that as well, because they could keep the baby wrapped in it while they're holding the baby. But of course we want to still allow some time for skin to skin as well. So just some considerations there. For the immune system, the baby does receive passive immunity for the first 3 months. This is the IgG antibodies. Those start developing in the baby's system from 14 weeks on. So by the time, some of the very important ones do happen though in the last like 3 weeks of pregnancy. So the baby will get the most effective kind of pre-established immune system from the mother if the baby goes to term, but they do start developing pretty early there. Breast milk, you've probably heard by now that breast milk has great immunological advantages to the baby. It is antimicrobial even in and of itself, which is why you can leave breast milk out for a certain amount of time before even having to refrigerate it, because it's almost, you could call it self-cleaning for a few hours. It also decreases the risk of immune-mediated conditions like inflammatory bowel disease, even type 1 diabetes, and allergic reactions like we talked about before. At birth, IgA is missing from respiratory, urinary, and GI tracts for all babies, but breastfed babies receive the IgA in the GI tract through the breast milk. So that can help some of those other conditions listed above. The greatest risk factor for any baby for infection is prematurity. But some other reasons are premature rupture of membranes, chorioamnionitis, and maternal fever. And then they do have a high risk of morbidity and mortality because of their immune system just not functioning properly yet. Excuse me. And we would be watching for the baby to be lethargic, irritable, poor feeding. Again, some of these, symptoms cross over into other, like hypoglycemia you might see with this. But if the baby's getting septic, you might also see decreased reflexes, mottled skin, tachypnea, and grunting, but not necessarily fever. Okay, that might be one of the later signs if seen at all. And that is also because the immune system is immature. It may not be responding that way yet. All right, talking about integumentary issues, and we'll share some pictures of each of these, but just kind of a quick review. Vernix is that cheese-like covering. It's antimicrobial and prevents fluid loss in the infant. It's almost like you're coating of Vaseline, right? So it protects the baby from just that extra fluid in utero, and it can help moisturize the skin once the baby's born. We do wipe most of that off if the baby's very cheesy, as we call it. We wipe most of that off at delivery, but we leave it in all the cracks and crevices because it can be good for the baby's skin. Erythema is just that the baby is red for the first few hours and fades. All this is normal, so everything on this slide is considered within normal. Acrocyanosis we talked about, also normal. Milia, that's the small, almost look like little whiteheads on the babies, often on their nose. They are just kind of clogged sweat glands, white pinpoint papules. babies don't actively sweat for the first 24 hours. Desquamation is that peeling. This is very common, especially in post-term births. It's one of the signs of like an over-mature kind of baby. Often the vernix is kind of already gone and their skin is peeling. Infantile hemangiomas. This is the strawberry mark. It looks just like, you know, a small strawberry, and it's raised, rough edges usually, and it's that dark red color. And nevus simplex is also called a salmon patch and stork bites. So you might see pink at the nape of the neck, and it's flat and smooth. It blanches easily, and it's very common in newborns. Mongolian spots are bluish-black pigmentation. They can be mistaken for bruises, but they aren't necessarily. Very common in a darker skinned individuals, so Hispanic, Latin American, African, Mediterranean, and you would document it, but it's not abnormal, and it fades, you know, as the baby grows. Erythema toxicum is a newborn rash. It sounds bad, right, because it's using the word toxicum, but it's really not, and it's kind of a splotchy red marks. It almost looks like the baby's having an allergic reaction to something, but and we call it a newborn rash, but it's still within normal. Very common to appear within the first day and can last for up to 3 weeks, but there's nothing to treat there, nothing really to do. It's just the baby's skin adjusting to life outside the womb. Lanugo is the word for that fine hair all over the baby's body. Very common at delivery, and then it just kind of disappears after the first week. However, some signs of possible problems would be central cyanosis, like we talked about, that circumoral blue, mucous membranes bluish. If the baby's having pallor, which again would be like a low blood volume, the baby's just pale and not perfusing well. Jaundice we talked about as well, so the baby's more yellow. And then petechiae are a more concerning sign of a possible circulatory problem, or I can't think of the word, but maybe a clotting disorder or something going on concerning with the baby's circulation. Here's this picture again. It's showing acrocyanosis. The blood is shunted to the major organs here. This baby looks like it could very easily be cold stressed. But again, even if a baby isn't cold stressed, it can have that acrocyanosis, and it's still normal within the first 24 hours. All right, so here's just some illustrations of each of those conditions that we talked about. Desquamation, this is kind of freaky looking with the eyes blacked out like that. But the skin is peeling here. This baby was probably post-dates. This baby has just a lot of fine hairs all over its body. This baby is very cheesy. This vernix covering it. Milia, these little kind of pimple-looking spots. Clogged glands there. One thing that wasn't listed on the other page is this Epstein's pearls. This can also be normal. This is on the roof of the baby's mouth. Here's a port wine stain that wasn't listed either. It's kind of similar concept to this nevus simplex or salmon patch, this nape of the neck pink spot here that does blanch easily. And then Mongolian spot. This is not a bruise as much as it may look like one, and that is normal finding. We would just document that. On to the reproductive system. The breast tissue in both sexes can be slightly enlarged. This is because of hypoestrogenism in pregnancy, and they may even have a thin discharge known as witch's milk. This is also within normal. For the male, obviously the baby's born uncircumcised, with the foreskin is adhered to the glands at birth. So we're not trying to retract that foreskin or do anything with it. Only the doctor would do anything with that if the baby is to be circumcised. But the doctor's doing their own assessment and everything, but we do want to assess, make sure that the urethra is coming out of the tip of the penis like it is supposed to, and not epispadias or hypospadias. So epispadias, of course, would be if the urethra is exiting out of the top of the penis. Hypospadias would be underneath instead of the tip. Cryptorchidism is undescended testes. So we want to assess the testes in a male as well, and they should both be descended. Torsion is an emergency. If you see one side of the scrotum is blue, you want to have that evaluated by a physician immediately, and it usually needs surgery. Hydrocele is more common, and it's just an accumulation of fluid around the testes. So the testes are extra large sometimes after delivery from extra fluid. Those can be transilluminated with light in order to see a little bit better what's going on, and if you can tell if the testes are descended into them. And then for females, you're going to have edematous external genitalia. Again, increased estrogen production in pregnancy can cause mucoid vaginal discharge, and it might even be slightly bloody. It's almost like a pseudo period, and some parents can be alarmed by this. You might hear the term brick dust. So that is, just kind of the red pinkish pseudo period kind of discharge that can happen in a baby girl in the first few days as their hormones are adjusting to extrauterine life as well. Okay, speaking of skeletal changes, molding, you have seen molding before. That's that football shaped head, right? The baby's head forms and changes to fit through the vaginal canal. The sutures are unfused in an infant, and they can bend basically and even overlap in the delivery process. So all this is normal. We are going to be assessing the baby's fontanelles, both the anterior and posterior fontanelles. The anterior fontanelle is much bigger and it's easier to identify. Posterior is a lot smaller. It depends on the baby though. Sometimes there's a big range there. But we're assessing those every time we assess the baby because it can give us an indication of dehydration. If the baby is very dehydrated, then those fontanelles will be depressed and sunken. But if they are bulging, then you would suspect intracranial pressure. So especially if there was any trauma, like birth trauma, anything like that, we would want to be assessing the fontanelles for bulging. And we assess head circumference for the same reason as well, if we're worried about any of those. Okay, moving on to some of the other things we're looking for the baby's scalp and skull areas. We're talking about caput, cephalhematoma, and subgleal hemorrhage. Caput, think of it as a cap that's you're putting on the baby's head, and you're putting the cap on more straight instead of off to the side. The reason I say that is that caput is going to be able to cross the suture lines. If it's crossing the suture lines, meaning it's covering parts of two cranial bones, then you know it is caput and not cephalhematoma. And caput is just like an intense swelling. It's very edematous, but it's often might be caused by a vacuum, or sometimes it's caused when the baby's head is putting a lot of pressure over the cervix, and its cervix is kind of squeezing, and it's just swelling down through the cervix before the cervix is completely dilated. You might see caput there. depending on the baby's position, if it's kind of stalled there in the vaginal canal, you could have caput and swelling in this one central direction. However, it disappears in 3 to 4 days. It's not really a concerning sign. It's something that we're watching and monitoring, but it's just basically just swelling and the body reabsorbs it. Cephalohematoma is has more considerations to it. So cephalohematoma is actual bleeding under the scalp. Perhaps blood vessels were broken when a vacuum was applied or some other kind of injury happened. So it's a collection of blood under the scalp, but it's kind of contained within this area that ends at the suture lines. So a cephalohematoma does not and cannot cross the suture lines. And that's kind of the difference, the hallmark difference between the two when you're looking externally and feeling externally. But you have this collection of blood under the scalp, and it can take 2 to 8 weeks to resolve. It can really kind of be there a long time before the body can break down all that extra blood that is collected there and clotted there. So you have this hemolysis having to happen, and these babies are much more at risk for jaundice because as the body breaks down the red blood cells and it's left with this unconjugated bilirubin that the liver can't quite handle yet, then the levels of bilirubin rise and the baby is jaundiced. So this one is more serious, something to watch, and something to watch for jaundice as well. Subgaleal hemorrhage is very, very dangerous. It's basically the baby could bleed out into their scalps. You can see in this picture just to the right, you've got at the top, you've got caput, the next one down is cephalohematoma, and then the one under that is subgaleal hemorrhage. So subgaleal also kind of crosses all of the suture lines, but it's filling up the entire scalp area because there's nothing to stop it. It just keeps bleeding, 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 and the baby's scalp underneath is just filling up with blood, and it can basically drain its entire blood volume out into its the subgaleal area there. There's nothing to stop that blood flow, nothing to kind of put pressure on it and clot it off. So the baby could go in hypovolemic shock or DIC there. So we are watching for signs of any of those as well. For our skeletal assessment, we're looking at the thorax. We're looking at the clavicles. We want them to be symmetrical, and we're testing for crepitus, assessing for crepitus, where we're just kind of pressing along the clavicular lines and feeling for any crunching, cracking feelings or sounds even. We would suspect a clavicle fracture there. Same for when we're doing our assessment, we lay the baby down and kind of watch it for a second and see if it's moving its arms normally and all of its extremities. If it's favoring one arm, then we might suspect a clavicle fracture there as well. We want to assess symmetrical scapula, a straight spine. Want to assess for any sacral dimples or hair tufts. This actually has, it's related to kidneys as well and neural tube defects. So we're looking closely there at the sacrum and just above the kind of the butt crack there. We're looking for clubbed feet, polydactyly or oligodactyly, so we're making sure that the baby has 10 fingers and 10 toes. And then we're looking for gluteal folds, which is what this picture shows here. This could be indicative of hip dysplasia. So we're looking, we hold the baby up, we look for these extra folds in one side or the other, and it could be caused by hip dysplasia. We could test for hip clicks as well. That might be something that the provider, a higher level provider, wants to do. Neuromuscular, we already talked about assessing for hypoglycemia in the baby, but as far as for telling the difference between transient tremors and seizures, if a baby is just jittery or easily startled, it's going to be something that we can elicit easily and we can stop easily. So like we grab the arm or touch the arm and maybe it calms them down. That's going to be different than if it's a seizure. We grab the arm and it just keeps shaking inside of our arm. Okay, so if we're trying to assess the difference there, that's what we would look for. Seizures also cause ocular changes, so we're looking at the baby's eyes, and it causes autonomic changes like apnea and tachycardia as well, whereas baby being jittery wouldn't necessarily. Hypoglycemia could cause some apnea, right? But we're kind of looking at the big picture here. We're going to assess muscle tone as well. If a baby's placed on its tummy for tummy time, it should turn its head to its side if it has adequate muscle tone. And then when we raise it, and it kind of holds its head in line with its body. Other reflexes here, rooting reflex, when we put our finger on the corner of the mouth and the baby turns to it and opens its mouth. Sucking reflex, we test, you can test sometimes with a pacifier, but with a clean gloved finger you can put on the roof of the baby's mouth and see if it is attempting to suck. The tonic neck reflexes, when the baby kind of extends the arm and leg on the side that it's facing. A stepping reflex will happen when you hold the baby up and touch the foot to a solid surface. It'll kind of step. Moro is that startle reflex. So we kind of let the baby, you can kind of gently drop the baby on a surface, not from a great height, maybe from like ½ an inch, onto a soft surface, and they kind of stretch their arms out and have this startle. Palmar grasp is when the baby grabs your finger. Plantar grasp is when the toes curl around. And then the Babinski reflex, you might remember this from Med-Surg. It's something that you should not see in an adult that you're assessing for neuromuscular injury, but it is normal and expected in the infant. So this is when you stroke the foot, we would expect the toes to flare out. That's the Babinski reflex. If any of these are diminished or absent, then we might suspect some sort of hypoxic episode or neurologic impairment that we would want to document and pass on to the doctor. Just as kind of a broad overview here, we're looking at what is a baby most at risk for if they're born within a certain range of development. So for babies born between 34 and 37 weeks, so 36 and 6, we would kind of expect the baby, we would anticipate issues with this, right? So if we are the nurse that's going to be, quote, catching the baby and caring for the baby in the first few hours after birth, if it's a baby between 34 and 36 and 6, we're going to anticipate possible respiratory distress or apnea, problems controlling its temperature, problems controlling its sugars. We're going to expect the bilirubin to be higher, and we're going to be monitoring that. And then feeding difficulties. So the baby just doesn't have the coordination yet quite for feedings to go well, oftentimes. If we're early term, so 37 to 38 and 6, we would expect possible problems with hypoglycemia and TTN, which is that transient tachypnea of the newborn. So we're looking for the baby to be breathing too fast and maybe needing to give it a little bit of help with oxygen for a while. If the baby's post-term, 42 weeks or greater, there is a much higher risk of mortality for the baby. Again, the placenta is just getting really old, and labor doesn't usually go as smoothly at that point. The baby also may be big. If the baby is macrosomic, remember there could be birth injuries, including the shoulder dystocia, clavicle fractures, different things like that. More likely to have meconium-stained fluid because of those issues with placenta and a decreased perfusion from the placenta. And then the baby's more at risk for aspirating that meconium. So we are concerned with that by that point as well. And then tachypnea could certainly go along with that. So just another kind of big picture here, what we're looking at for physical assessment for the baby. We're looking at the general appearance, neurological assessment, gestational age assessment. A lot of times this is done by plotting information on the chart from what we've gotten. There are other types of scoring, like the Ballard scoring for estimating gestational age, which takes into account things like the skin peeling. But those aren't always done now. Still good information to review. But we're assessing the baby's vital signs, know the heart rate and respiration rates, how long is apnea okay in a baby before we're concerned, know the normal temperature range for the baby, and then the weight there, anything from 2,500 to 4,000 is kind of within normal, right? So that would be called AGA, average for gestational age. That's plotted on a chart, plotted on a graph to decide what is the average weight for that gestational age. But LGA would be large for gestational age, and SGA would be small for gestational age. And those two categories are both at risk for hypoglycemia as well, and we would be monitoring blood sugars in both of those cases. They would be on a hypoglycemia protocol that would tell us how often to check their blood sugars. We're also assessing the height. You know, we measure what we would call the length of the baby, but it's the height, and the head and chest circumference. If the head is 2 centimeters bigger than the chest, then it might be because of growth restriction. It might be cephalohematoma or increased intracranial pressure. So we're assessing those because we want to make sure that they're within the normal range there. So we've covered kind of our initial assessment, what we're looking for in the first 2 hours of birth, after birth. But now from 2 hours to discharge. Some common problems there. We're continuing to watch any birth injuries, soft tissue injuries like bruisings, abrasions, accidental lacerations that can happen sometimes in like a C-section, for instance. Skeletal injuries might be the clavicle or the humerus, especially if there was a shoulder dystocia. Caput and cephalohematoma are near skeletons, but they're not. They're just they're still soft tissue injuries. Looking at hypoglycemia, temperature instability. Again, we're looking at jaundice and breast milk jaundice, breast milk related jaundice, and then ABO incompatibility. I mentioned this briefly, but it's again relating to jaundice that we're testing the baby's Coombs. We take a Coombs test, and if they're Coombs positive, then we're going to go ahead and put them on a jaundice protocol, put them on lights, and make sure that the baby doesn't get toxic levels of bilirubin. So we're mitigating that early. Here is a case study that I will let you review on your own within the PowerPoint there. A couple other things we're going to look for here, just our standard laboratory and diagnostic tests. We're doing the metabolic screen at 24 hours old. We used to call it the PKU, but now it's really called the newborn screen because it tests for many more diseases than just the fetal ketonuria. But it can test for sickle cell and all sorts of other diseases as well. So this is a standard test we give to all babies, and that's what's in this picture here. We get just a few drops of blood. We also test CCHD. It's a simple oxygen saturation reading. We get a pre and post ductal pulse ox, and as long as there's not a 3% difference between the upper and lower extremities, then they pass their CCHD, and we don't suspect any congenital heart disease. That screening that we're screening for there. The baby's also going to get a hearing screen, and if the baby's born less than 37 weeks, then the baby will get a car seat challenge as well to make sure that they can maintain their O2 sats while they're sitting in a car seat, to make sure that they don't desat on their way home from the hospital. When we collect specimens like the newborn screen, or the PKU as we sometimes call it, we're usually doing a heel stick. You can see in this diagram the preferred sites are kind of lateral on the heels. If you aren't careful, you can cause, you could get as deep as the bone or cause nerve injury to the baby, so we're trying to be careful there. You want to warm the heel first and make sure that you get adequate blood flow there. And you do the same thing, by the way, when you're checking a blood sugar. You want to make sure to warm the site to make sure you get an accurate reading. You can sometimes, if you already are needing to draw blood or you're just having trouble, you can do venipuncture to draw blood there. They have special, we call them U-bags or urine bags to collect urine specimens or stool specimens if needed, which would be maybe to test if a mother has history of drug abuse, and we're testing if the baby is processing those drugs at delivery, or the stool specimen shows like a longer history of it, because we need to know if we need to help treat and teach the mother, but treat the baby as well for any withdrawal. In all of these cases, we want to try to comfort the baby as much as we can. If we can perform it while performing skin to skin or even breastfeeding sometimes, a non-nutritive sucking with a pacifier, or swaddling. We also use sometimes Sweeties, which is just like sweet water, sugar water, to help with that. Protective interventions. Rooming in is kind of a protection built in. The mother and baby are in tune with each other and really watching the baby. We're going to make sure that we provide good hand hygiene and gloves. We're monitoring, most labor and delivery units are locked units, but we also have I call them a baby low jack, kind of. It's a tracking motion. If the tracker comes off of the baby's, out of contact with the baby's skin, it will set off an alarm and lock the unit down until we figured out what is going on, and of course the ID bands as well. We want to teach the parents that the baby should, baby should be on its back, supine, in the crib. Recommend elevating the head of the bed 15 degrees to help prevent choking if the baby should spit up. Sudden unexpected postnatal collapse is it's basically sudden apnea or cardiorespiratory failure. If you have a mom calling and saying, my baby's blue, what's the matter? We're going to start PPV as quickly as possible, and if needed, run a full code. But this is part of the reason that during recovery, we're watching the baby really closely for those first 2 hours. We talked about most of these injections already. The HBIG would be if the mom is positive for hepatitis B, then we would give the baby HBIG to help prevent any infection of the baby. And then talking about circumcision here, in this picture, the physician is using the Gomco, and that's just one of the methods of circumcision. Circumcisions are, of course, up to the parents to decide if they want to do it or not. If you look in your book, and this book is a new edition, so it has kind of the most recent information, but basically, depending on where you go, which country you're in, will differ whether it's recommended or whether basically they abstain from recommending one way or the other. But you can do your own research and look in the book and kind of see where you stand on the issue. But circumcision can help prevent infection and even sexually transmitted diseases, including HIV later in life. So it's overall generally recommended, but not necessary, is kind of the, I would say, the overall consensus on circumcisions currently. It is contraindicated, though, in the event of hypospadias and epispadias. They would want to repair, make any repairs first. Depending on the procedure will depend the care of the circumcision. There are certain types that you do not put petroleum or petroleum gauze on it, and certain types that you do. But the main things after circumcision, we're monitoring for bleeding. We don't want the baby to bleed out because, again, any bleeder in a baby can cause problems very quickly because they just don't have that much blood volume. Also looking for signs of infection and making sure that the baby is able to void after the procedure. We do provide pain relief for these babies. It might be a nerve block, might be topical anesthesia, and might be non-pharmacological relief, or a combination of all three. Pain. If a baby is in pain, we're going to, of course, see changes in its vital signs, often see crying. There are several scales to assess infant pain, and your facility will have one standard, I'm sure, and you just kind of go through and click each one. And we're going to just do the best we can to minimize the intensity and the duration of the pain. And some of the non-pharmacologic methods we might use are swaddling, non-nutritive sucking, again with the pacifier, kangaroo care right there, skin to skin with parents, breastfeeding, distraction, and even infant massage. As the baby goes home, we are teaching the parents all the things, including avoiding overwrapping the baby, when to call the doctor, when is something important, how to prevent suffocation, how to use the bulb suction. We're, of course, giving lots of information on breastfeeding, how to know that the breastfeeding is going well. That's the 6 to 8 diapers a day. Okay. We want to advise them on what is normal as far as rashes go, how to prevent or treat a diaper rash. Rule of thumb for babies as far as clothing the baby is whatever you are comfortable in, then add one extra layer for the baby, and that is what we would recommend having the baby dressed in. We're going to teach car seat safety. We're going to teach about SIDS, how to bathe the baby and care for the cord, and the basics of infant CPR, and just assessing what does the baby need right now, why is the baby crying, and how can we help. Some things that we are going to teach for signs and symptoms of a sick newborn, and things for you to know. You're going to tell the parents to notify the provider if the baby is too lethargic, you're having trouble waking the baby after a long period of time, right? If the temperature is above 100.4 or below 97.7, we want to contact a provider. Large amounts of emesis, green liquid stools, refusing 2 feedings in a row. If the baby is not voiding 6 to 8 times in the day, or 3 stools in a day. And then, of course, difficulty breathing, cyanosis, pale mottled skin. If you cannot console the baby, especially that high-pitched crying, sometimes any signs of symptoms of infection, right? So bleeding, drainage, foul odor coming from the umbilical cord or the circumcision site, and then drainage from the eyes. Last but not least, neonatal abstinence syndrome. This is when a baby is born to a mother exposed to drugs and narcotics in utero, and unfortunately these babies are born withdrawing. They already are experiencing some signs of withdrawal oftentimes because while the mother was in labor, she wasn't able to take those drugs either while she was in the hospital. So many of the drugs cross the placental barrier and the baby's born addicted. They can have long-term developmental and neurological deficits because of this. And some of the things that you might see as a baby's withdrawing are this high-pitched crying. They can even have seizures. Their temperatures are unstable, certainly tremors. They're having trouble sleeping. They might sneeze a lot and having trouble with their feedings. So we would teach the mom how to care for these babies. So if we're seeing a baby is having tremors and difficulty feeding, we might see increased yawning, even sneezing. We're gonna suspect that the baby might be withdrawing from something and maybe investigate a little bit more. And now for next week, we are going to be looking more into newborn nutrition and feeding and high-risk newborns. We're taking quiz 5 in class over the material that we just covered, plus a couple of questions from next week's material. Work on your CJSIM and NCLEX questions and discussion number 4. Also, your review sessions for exam 3 are going on this week, and I hope you can make some of those. Thanks. Bye.